Welcome to this Step 3 review on peripheral neuropathy and weakness, brought to you by Roadmap to Residency. We are not reteaching the nerve chapter today. We are showing you how these stems are built, which details the writer's plant on purpose, and how to turn those details into the right answer in under a minute. Nerve stems look intimidating because they are long, but they are formulaic. Learn the patterns, and this becomes one of the most predictable topics on the exam. Keep your question bank open alongside this video. Let us get started. Here is what we are covering. First, the 4 signature stems that carry almost every nerve question: the long-standing sugar picture, the hidden vitamin deficiency, the ascending weakness emergency, and the stem that is really asking about nerve testing. Second, how to separate slow-burning feet from the emergency that climbs upward, because confusing those two is the costliest error in this topic. Third, exactly when nerve conduction studies belong in your answer, and more importantly, when they are the trap. We will walk through 3 full practice questions and explain why every choice is right or wrong. Strategy 1 is to sort every nerve stem by tempo and direction before you read the choices. Start with tempo. Find the sentence telling you how long this has been going on, because it is always there. Months to years of numbness is chronic, and chronic means metabolic or nutritional. Days to a week or 2 of progressive weakness is an emergency until proven otherwise. Tempo alone eliminates half your options, then find direction. Is the deficit sitting in the feet and hands or marching upward from the feet toward the trunk? Symmetric burning that stays distal is a chronic length-dependent process. Weakness rising toward the thighs over days is the ascending pattern, and that changes everything. Strategy 2 is to separate numbness from weakness, then read the reflexes. When a stem leans on burning, tingling, and loss sensation while telling you strength is normal, it is pointing you toward the chronic metabolic and nutritional causes. When a stem leans on, cannot climb stairs, cannot rise from a chair, or dropping objects, that is a motor stem, and motor stems carry urgency. The reflexes are a free answer. Absent reflexes with rising weakness over days is the emergency pattern. Absent ankle reflexes alone with years of numbness is expected chronic disease. And if reflexes are brisk or increased, stop, because that is not a peripheral nerve problem, and the answer lives in the spinal cord. Strategy 3 is to memorize the 4 signature stems. The first is the long-standing sugar stem. Years of high blood sugar, burning and numbness in both feet, absent ankle reflexes. This is the most common stem in the topic, and the answer is almost never a nerve test. It is better sugar control and a medication for the burning pain. The second is the hidden vitamin stem. Look for the planted giveaway: a strict vegan diet, a weight loss surgery, long-term use of a stomach acid blocker or of metformin, or a large red beefy tongue. Add lost position and vibration sense, an unsteady walk, and large red blood cells, and the answer is the vitamin level. The third is the ascending emergency stem, a stomach bug or respiratory infection. Weeks ago then, symmetric weakness climbing from the feet over days, reflexes gone, sensation intact. That stem is asking one thing: will you protect the breathing first? Let us work our first practice question. A 58-year-old man with type 2 diabetes for 12 years has 2 years of burning and numbness in both feet, worse at night, stopping around his ankles. Strength is normal. Ankle reflexes are absent, and vibration sense is decreased. His long-term sugar measure is well above goal. The question asks for the most appropriate next step. Run the filter as you read. What is the tempo? What is the direction? Numbness or weakness? What are the reflexes doing? Commit to a choice, and we will walk through all 4. Step 1. Spot the pattern. 12 years of diabetes, poor control, 2 years of symmetric burning, stopping at the ankles, absent ankle reflexes, normal strength. Every element is the classic slow, symmetric, distal, sugar-driven picture. Nothing atypical to chase. Step 2. Apply the rule. When the stem hands you a textbook picture with the cause already named, the exam wants treatment, not confirmation. Improve the blood sugar control to slow the damage and start a medication for the nerve pain. Step 3. Eliminate. Nerve testing is the trap, and the most seductive one in this topic. It confirms what the history already proved and changes nothing. Spine imaging is wrong, because the deficit is symmetric in both feet, not in one nerve root. Nerve biopsy is reserved for rare, unexplained cases. Our second practice question is all about the planted detail. A 62-year-old woman has 6 months of numbness and tingling in both feet and both hands, with an increasingly unsteady walk. She had a weight loss surgery 8 years ago and takes a stomach acid blocker daily. She has decreased vibration and position sense and an unsteady stance with eyes closed. Blood counts show a low red cell count with unusually large red cells. As you read, ask why the writer mentioned the surgery, the daily medication, and the size of those red cells. Nothing in a stem this specific is an accident. First, hunt for the planted detail. The weight loss surgery and the daily acid blocker both block absorption of the vitamin, and that is 2 hints pointing the same direction. The hands are involved as well as the feet, unusual for a purely distal process. Position and vibration sense are lost, telling you the back of the spinal cord is involved. And the red cells are large. The stem names the deficiency without naming it. Now, why does the cheap test win? When a simple blood test confirms a reversible cause, it comes before anything expensive or invasive. Nerve testing tells you a nerve is damaged, but never why. Treating the pain without finding the cause lets a reversible spinal cord injury become permanent. Brain imaging does not explain symmetric findings in all 4 limbs. Now let us settle when nerve conduction studies and electromyography actually belong in your answer, because this is where most people lose points. Start with the default. The answer is no nerve test. If the stem hands you an obvious cause and a textbook picture, nerve testing is wrong. It costs money, takes time, and confirms what you already know. That single default will earn you points on the most common stem in this topic. So when does it become correct? When the story breaks. Reach for it when weakness dominates without a clear cause. When findings are on one side or in one nerve territory. When the deficit is proximal rather than distal. Or when the stem is deciding between a nerve problem and a muscle problem. The shortcut: if the stem says the diagnosis is uncertain, the nerve test is on the table. Our third practice question, and the tempo should hit you immediately. A 34-year-old man comes to the emergency department with 4 days of weakness that began in his feet and has climbed to his thighs. 3 weeks ago, he had several days of diarrhea. He has mild tingling, but sensation is largely intact. He cannot rise from a chair without help. Reflexes are absent throughout, and he feels short of breath when lying flat. Notice how different this feels from our first 2 questions. Look hard at that last detail, because the writer did not put it there to fill space. First, recognize the emergency. An infection weeks earlier, symmetric weakness rising from the feet over days, reflexes absent, sensation spared. That is the ascending emergency. And shortness of breath lying flat is the exam telling you in plain language that his breathing muscles are failing right now. Now the key distinction, and this is what makes it hard, every wrong choice is a real part of the workup, and that is the trap. The spinal fluid study and the nerve test both support the diagnosis, but neither keeps this man breathing over the next hour. Steroids are not effective here and are a pure knowledge trap. The rule to carry in: when a stem plants respiratory failure, monitoring the breathing outranks confirming the diagnosis. Here is the pearl that ties it together, a 4-question filter you can run on any nerve stem in 15 seconds. How fast? Years means metabolic or nutritional. Days means emergency. What direction? Staying distal, or climbing upward? What kind? Numbness or weakness? What are the reflexes doing? Absent fits a nerve. Increase sends you to the spinal cord. 4 questions, and most stems collapse to one answer. Then watch the 2 traps. The first is ordering a nerve test on a stem that already told you the cause. The second is confirming a diagnosis, while the patient is losing the ability to breathe. Both feel thorough, and both are wrong. When a stem plants a diet detail, a surgery, or a stomach medication, that is a deficiency question. When it plants trouble breathing, that is a breathing question. That wraps up peripheral neuropathy and weakness. Sort every stem by tempo and direction before you read the choices. Learn the 4 signature stems on site. Make no nerve test your default and reach for it only when the story breaks. And when the stem plants trouble breathing, protect the breathing before you confirm anything. To lock this in, work the nerve and weakness sections of your question bank under timed conditions and read every explanation, even the ones you got right. Pair that with the peripheral nerve chapter of a trusted review book and the neurology section of your board review question resource. Look for the chapters on nerve disease, vitamin deficiency, and the ascending weakness syndrome, rather than any page number, since editions change every year. Visit roadmaptoresidency.com for expert tutors and residency advisors who can build you a personalized study plan. If this helped, please like and subscribe so you do not miss our next board review session. Good luck on your exam.